Good afternoon, everybody, and welcome to Grand Rounds. Today, it's my pleasure to reintroduce Dr. Lauris Kaldjian. Dr. Kaldjian is an internist, infectious disease physician, and medical ethicist. Attended medical school at the University of Michigan. He did his training in internal medicine and infectious disease at Yale, where he also received a Master's of Divinity degree and a PhD in religious ethics. He currently is a professor in the Department of Internal Medicine. He has been very extensively published in the field of medical ethics, and the CME committee is very appreciative of his accepting our invitation today to provide a review of navigating disagreements with patients and ethical approach. And please join me in welcoming Dr. Kaldjian.
Great. Thank you so much, Dr. Halberg, and for Tim for arranging all the tech behind here, for Amber for her emails. It's a pleasure to be with you again. I'm sorry I'm not there in person this time, but it's a privilege to be able to talk about, in a sense, a really basic area. This idea of disagreements with patients, and I don't. It sounds pretty negative, right? It's what a way to start one's afternoon on a sunny but albeit cold day here in Iowa. And so it's not that we're trying to look at the glass, half empty instead of half full. It's just to be honest about the fact that even though thankfully I hope it's true for all the clinicians listening to this, that you can say that the vast majority of the time, you're even if there can be some differences between clinicians and patients, by and large, you have the sense that we're on the same page, and patients come to us for help, and we are eager to want to be givers of that help. And things by and large go well. But we also know that all it takes is for one bad, serious, deep disagreement to interrupt your day and your patient's day, and it's hard. And I suspect that if you're like me, you can remember a fair number of these kinds of disagreements over time. My hope here today is to really not be that complicated, even though I have, 40 plus slides or so. But the hope is to, in a sense, I think of two words: clarity and confidence, to try to clarify what, in one sense, I trust you already understand. And so I'm pretty modest in my expectations here, but then also potentially to increase your confidence, if I could hope for that, in the sense of by putting certain names, terms, and labels to things to say, okay, that allows me to justify a certain approach to these situations. That's sort of my hope here. So here you can see the objectives to describe an ethical framework for shared decision making based on respect for persons and conscientious practice. So there's sort of a bifocal sort of view here. To clarify the ethics of persuasion. I like this word persuasion, even though it's a very loaded word and one needs to unpack it. And then apply a basic, pretty simple, twofold ethical framework for shared decision making to disagreements in two contexts. One would be a very classic case of the hospital discharges that go against medical advice, the so-called AMA discharge moment. And then on the other hand, potentially inappropriate or futile treatments where patients or families request or demand things that the clinical team doesn't think are appropriate or reasonable. Okay. So a couple examples just to start out the conversation here, as it were. So one day I was in clinic, an outpatient general medicine clinic, and a woman with diabetes presented to me and complained of right thigh pain, mild nausea, and malaise. And on exam, she had a low-grade fever, and her right thigh, sure enough, showed a large area of cellulitis. I didn't have any doubt in my mind about the significance and the degree of attention that it needed. So I recommended admission to the hospital for IV antibiotics and monitoring. But the patient said no. And instead, she requested oral antibiotics and said she had to go home. And this was a case that I can remember in my own clinical practice where I tried to persuade this patient to change her mind, and I was not successful. And in the end, I actually learned what the main driver for her desire to go home was. And the two has stuck with me because it was, I think, the only time this has happened to me as an explanation. And that was the patient had a cat, and that cat had had a heart attack and needed its heart meds administered at home that day. So the patient wanted to get home. So there's one example of where we as clinicians make a recommendation, maybe even a strong recommendation, maybe even try to persuade, patient says no, and we accept that. Okay. By contrast, sometimes you might say in a hospital, a different kind of situation. Let me put it this way, okay? So, and this is a true story, and I have permission from an anonymous surgeon source to use this story. A surgeon recommended a blood transfusion for one of his patients. The patient declined the recommendation. The surgeon confirmed the patient's decision in the presence of the patient's daughter and then documented the following. He wrote in the chart, the patient does not accept blood products. I do not know why, and I did not ask. It is none of my business. It is 2024 in America, and people make their own informed decisions on this matter, and I avoid engaging in confrontational ethical discussions on this topic. She and her daughter confirmed definitively that she would not accept blood under any circumstances, even if death were imminent. I respect her autonomy and will not transfuse. Now, I wasn't there to witness what happened in this case. All I have is this note. I also know something about this individual and the remarkable esteem in which he is held by the people who work with him. But my own sense would be that this surgeon probably did at least some of what I might call persuasion, but maybe not as much, because certainly the way the note is written would suggest that he's perhaps more willing to take no for an answer and then move on than I or someone else might be. I or someone else might decide to try a bit harder to do some persuasion if we thought the patient really needed, in this case, the blood products. So part of what I just want to begin with is to say that I think that as clinicians, we're all to some degree different in this regard. Some of us are more inclined to lean in and to keep trying to help a patient change his or her mind. Others are more, hey, it's the patient's decision. I gave them the information. If they say no, I need to accept that. So that's the kind of contrast I think this conversation is really getting at as a reality. So, as already mentioned in the objectives, the two main focal points here are respect for persons or patient autonomy, if you want to use that language, versus conscientious practice. So the respect for persons, in a sense, puts patients in the foreground, and conscientious practice puts you and I as clinicians in the foreground. Now, it's not, I don't mean to say that it's a competition between the patient and us, but rather it's sort of the where what are you looking at? Because when I say conscientious practice, I'm talking about the experience that you and I have as clinicians when we feel convicted about an obligation to try to help another human being, in this case our patient, understand what we think is in their best interests. Right? So it's to the respect for persons or respect for patient autonomy. In one sense, the more immediate sense is okay, I provide information, the patient makes a decision, I respect that decision, the patient's self determination. Whereas I'm trying to get at with conscientious practice that, oh, my patient says no or no thank you or declines. What is my obligation to try to promote their best interests, even if they have at least initially told me no? Okay, that's the kind of tension that I'm trying to get at, and I'll unpack that some more. So, what should we do when a patient refuses a recommendation? Do we accept and move on? Do we engage and discuss? Do we try several more times? So you can see here by this color coding that I like to talk when I'm talking with our medical students here in Iowa. I put up my hand and I say 5 words: inform, recommend, persuade, but don't manipulate or don't coerce. Right? But these first three, the inform, recommend, and persuade, it's as if there's an increasing strength of leaning into the patient. And I think different clinicians are temperamentally different in this regard. As I said, some are more inclined to lean in, some are less inclined. So I believe actually that persuasion, by that or any other name, it happens in medicine. Context also matters, right? In emergencies where you're like 98% sure that the patient's going to suffer really bad harm if they do what they say they want to do, no question, I expect most of us are going to lean in more as opposed to things that are much less certain than that. And then also that clinicians differ. I think we need to respect each other in the sense that some of us are going to be more inclined to communicate in one way or another. And I think that's just, I think we need to accept that at a certain level. So within the doctor-patient or clinician-patient relationship, we can say that there's a certain moral dynamic, right, within this thing that we call shared decision making. And I would suggest that when disagreements arise, we need to appreciate this moral dynamic with even more clarity. And so it's basically saying that two or more, and I say two or more because there can also be family members or others involved, or other clinicians involved in shared decision making. When two or more people share perspectives about what is or seems best for a patient. And then what I just want to really emphasize is that in the standard language of bioethics, right, beneficence, non-maleficence, autonomy, and justice, is that what we're really, I think, getting at is a tension between autonomy on the one hand and beneficence and non-maleficence on the other. That's just, I think you understand this already, but that's what I'm trying to unpack here. So if you look at these standard approaches to principles in ethics, at least in biomedical ethics and biomedical research, you can see the four principles here. It's these first two compared to the third one, versus if you're in the biomedical research ethics context, there are only three principles, but basically the first one covers both beneficence and non-maleficence, and then it uses the language of respect for persons. But if you haven't dwelt on this already, I think we all need to quite regularly, actually, is that when you have four principles or three principles, there are going to be, at least sometimes, tensions between them. So I think these navigating disagreements conversations are very much about dealing with the tension between these different principles, because there's got to be some way to navigate and to prioritize and to reconcile those tensions when they occur. So just to tag quickly what I know you know, but just to say that I'm aware that we need to do proper informed consent and whatever else we're saying about shared decision making. And we need to take even what the law requires seriously in this regard, right? So you can see these familiar elements of informed consent. And I agree with those who say that at its best, the process of informed consent is indeed a process. It's not just a form to be signed. It's a process, and it's a process of shared decision making. There's genuine opportunity for back and forth conversation and questioning, which is, I don't take that for granted at all. And I've certainly experienced that as a patient or a family member as well, right? Clinicians are busy. We're busy, and giving things time is something that sometimes takes a little more intentionality because we're always in a rush. Okay. Then another area that I sort of take for granted that we're on the same page for, that is decision-making capacity. Here are the four elements that I trust you're familiar with: communicate, understand, reason, appreciate. Okay, I'm not saying it's easy to actually implement this at the bedside or in the clinic, but this is an important construct. If you're not aware of these four elements, I would encourage you to basically memorize them and remember that this is the classic reference that most of us in bioethics will refer to when we're trying to give guidance about how to assess decision-making capacity. But the idea of deciding exactly where to draw the lines of whether we think a patient does or doesn't have decision-making capacity is borne out in this slide. It's a complicated slide in one sense, but the simple way to think about it is here in this column, is that basically when doctor and patient agree about what should be done, there's a lower threshold, meaning to say that we're not going to demand as much evidence from our patients that they have the higher or highest levels of decision-making capacity. Whereas if there's disagreement, clinicians just, I think, intuitively and reflexively and commonsensically, we say, oh, wait a minute, maybe my patient lacks decision-making capacity because it doesn't make sense to me that they're not seeing this the way I'm seeing this. Okay? I'm not saying that if there's agreement, you don't have to worry at all because, hey, the patient's nodding his head and it's a go, and I don't have to worry about informed consent. No, no, no. You still have to worry about informed consent. You still have to make sure they have a sufficient minimum level of capacity. But the point is that there is this thing that we call sort of a sliding threshold. Not everyone agrees with this. The authors I'm citing here, they agree with it, and they're very well-known people in the field. I happen to agree with it. It makes sense to me, but I think it'd be interesting for each one of you, those of you who are clinicians or have been clinicians, to reflect on how it is that sometimes you would expect and demand more evidence to confirm capacity, or you might demand less depending upon the context. That's the basic point I'm trying to make there. Okay, so the basic models of decision making are here, and so the shared model can be placed in the middle of either the informed information sort of giving model versus they use the language of paternalism, the paternalistic model, or you could call it maternalistic or parentalistic, whatever you would prefer. But the point being is that the shared model is this two-way street, basically sort of a dialogue or a partnership between the clinician and the patient. So what I'm trying to emphasize here in ethics language, right, is that shared decision making is trying to combine the patient's values and preferences or respect for their autonomy with the clinician's guidance based on a sense of the patient's best interests, which we could refer to in the ethics language of beneficence and non-maleficence. And there are different definitions of shared decision making out there. This is one that I've found that I actually think states the matter very helpfully because it says that this process, when it happens properly, it results in an interpersonal, interdependent process in which the healthcare provider and the patient relate to and influence each other as they collaborate in making decisions about the patient's healthcare. You can see I've underlined the word influence because I think sometimes there's some clinicians, certainly some medical students, who think that's, well, no, the clinician's not supposed to influence the patient, such that sometimes I get the sense that some medical students might have been led to believe, and I think mistakenly, that we're not even supposed to make a recommendation, right? Well, what's a recommendation? That's an effort to influence your patient, right? And then persuasion is to try even harder once they have initially declined or refused that recommendation. So, in a sense, I'm not shy of using words like persuasion or the idea of influence. The question we'll certainly land on in the end is we don't want to overstep our boundaries, right? It's one thing to say that, hey, I'm here to give advice to my patient. And I'm not shy about saying that I have an influential role to play in this process. But it's a very different matter. Again, remember those 5 words when I put up my hand and I said we should not manipulate or coerce. So at a certain level, after I believe I've done my due diligence and I've fulfilled my responsibility to try respectfully to persuade, there comes a point when I need to stop. And I just need to respectfully accept the fact that my patient sees it other than I do. And that is as it must be. Just as an aside related to these things, there is a lot of legal background to notions of patients having the right in our society as a legal right to say no or no thank you, or to be allowed to say yes. And this was a famous case from over 100 years ago now that basically found a surgeon guilty of not getting consent from a patient regarding a surgical, an extension of a surgery that hadn't been agreed to in advance. So, except in cases of emergency that have their own sort of discussion, we need to respect our patients when they say no, or when we're offering something when they say yes. But along these lines, too, when we talk about autonomy, I agree with those who would suggest it's sometimes in a more superficial way, some people treat, I think, autonomy as mere choice. So all we have to do is give our patients information, they give us a choice, and we're done. As opposed to, wait, help me understand the rationale for that choice, the basis for that choice, to see if I am persuaded that this is really coming from what your deeper preferences and values and beliefs really are. And so one author has suggested that sometimes autonomy might be seen as the affirmation of choice itself, where all options are equally worthy because they're freely chosen, and it's choice itself that confers worth, as opposed to the goodness or the substance of what's being chosen. Right? This is getting philosophical. I realize that, but I want to tag that to say that it's that so this language of choice, which is very prevalent in our society, and I think also in healthcare, it's something that should be a bit of a flag that pops up and makes us think, okay, what do I mean by choice, and how does that relate to a respect for my patient as a person? So, and that brings us to this notion of relational autonomy. If you haven't come across this yet, I encourage you to think about it. Um, and those who talk about it, this is one example of a philosopher who does, is points out that autonomy is a socially constituted capacity, meaning it's not just about isolated individuals making decisions by themselves in the universe, right? It's actually that we are interconnected and interrelated. We need each other, basically, and we benefit from being in dialogue with each other. And so this author recommends that a relational view of autonomy requires recognizing a person's dignity, being obligated to understand that person's perspective, right? So that they're subjective, not in the cheap sense of that word, but in the word of that the person as a subject, as a human, as a person, not just as an object of healthcare. And then thirdly, to the point here, that we have in a relational autonomy sense an obligation sometimes to try to shift a person's perspective and promote her capacities for autonomy by enabling her to reevaluate and revise her perspective and her reasons for acting. Now, I would hope that every one of you listening to this can think of situations where you and or a friend or a loved one or maybe a patient have been in situations where you were the beneficiaries of exactly this phenomenon, that you were in the process of making a decision and talking to somebody about it. You'd made up your mind, and then somebody heard what you said and thought, wait a minute, do you realize what you're doing or not doing? And then you have this back and forth, this dialogue, and by the end of it, maybe either within that one meeting or subsequently, guess what, you changed your mind, or somebody else changed their mind. I trust that we've all had that experience. That, I believe, is what exactly this idea of relational autonomy is getting at. So, another topic to bring into this, or another way of talking about related things, would be the patient's good. Because the patient's good, this idea, at least the way some of us have grown up using this phrase, it's basically getting at the patient's best interests, and it's on the beneficence and non-maleficence side. Okay, and so this basic schema, this is a slide that I commonly use, is just to say that basically what we're doing in healthcare is trying to promote the patient's good. And so it's all the treatments and tests that we do are oriented or directed towards goals of care, and these goals are directed toward our patient's health, and their health is part of their flourishing, right? And so the patient's good is the health and the flourishing sort of together, but especially the health side of it is the scope of expertise. So, as we'll talk about, and I'll give a case or two in just a little bit here, when we get into situations where we believe your patient is about to make a dangerously mistaken decision that you believe is highly likely to bring harm to them, either loss of life or limb, whatever it might be, your expertise is to bring to your patient's attention a sense of what the health implications of that decision will be and how you believe that their good, your patient's good, deserves more consideration and you believe a different decision. Okay? So, when we talk about goals of care and goal-oriented decision making toward health and flourishing, et cetera, we also, of course, have to keep in mind other dimensions of decision making. And this is the basic construct that's always on my mind based on thinking about this over the years. And then I think any good informed consent conversation with patients it really ought to be covering this terrain, because if it's not, then some major deficiencies are present in that conversation. So I'm going to come back to this when we talk a bit about this idea of medical so-called futility. Come back to that. So another topic here is this bifocal view, the twofold. On the one hand, respect for patients as persons or their autonomy. On the other hand, the beneficence and non-maleficence or best interests. And remember, I talked about conscientious practice as being a way to foreground our sense of what we think would be best for our patients. So when I talk about conscience, I find Webster's dictionary to actually offer a very useful definition: a sense or consciousness of the moral goodness or blameworthiness of one's own conduct, intentions, or character, together with a feeling of obligation to do right or be good. So, conscience is a moral awareness involving our moral perception, our own self judgment, and a sense of moral obligation. So, it's really serious. It involves who I am as a human being, both as an individual and also as a professional. This sort of idea, I think, is actually very much sort of backed up by at least one empirical study of over 1,000 practicing US physicians who were asked, basically, where do you get your moral guidance as a physician? And you can see different things listed here. Look at the percentages in this far right column. The only one that is really high is personal sense of right and wrong. That's what conscience is getting at as well. So, when we talk about conscience, we're also very much, I think, talking about virtue ethics. And this is a busy slide. And for those of you who are more familiar with ethics and ethical theories, you'll see a lot of familiar stuff in this table. But the point is that we're usually in bioethics talking about principles that are focused on acts or actions, whereas conscience is really in the domain of virtue ethics. And it's about our own sense of our own identity and integrity as we fulfill our responsibilities as human beings and in the healthcare context as professionals. And when we're in situations that are stressful and where there are tensions and there are disagreements, we may experience something that at least some might label under the rubric of moral distress. And if we don't deal with these situations more straightforwardly, I think there will be risks of moral injury and burnout and things like that. There's more to be said about this. And anyone who is interested in more literature on any of these topics, please email me and I'd be happy to send you some PDFs, including the reference to a piece that I myself wrote on this topic. So now moving on to some clinical scenarios to unpack some of this in real situations. So here's a situation of a patient who is basically insisting on the so-called AMA, or against medical advice discharge. This was a 62-year-old man who presented to the hospital complaining of progressive shortness of breath over 10 days, apparently due to decompensated heart failure and worsening renal function. The past medical history was significant for diabetes, stage 4 renal failure, congestive heart failure, coronary artery disease, had 2 MIs and 2 stents in the last 3 years, and transient ischemic attacks, or TIAs. With medical management in the hospital, his shortness of breath began to improve. But on the 4th day of admission, he developed palpitations and labored breathing and was noted on telemetry to have ventricular tachycardia lasting about 30 seconds with spontaneous resolution. The patient acknowledged having had similar episodes of palpitations and shortness of breath prior to admission. Cardiology was consulted and recommended prompt catheterization given the possibility that cardiac ischemia might be causing the ventricular tachycardia. The patient was upset by this news that a cardiac cath was being recommended and said he wanted to go home. He was frustrated that he was not getting any rest in the hospital. Sound familiar? He also said that if God willed that it was his time to die, then he would accept that. The risks of leaving the hospital without a proper evaluation were discussed, but the patient was adamantly opposed to cardiac catheterization and insisted on being discharged without further delay. This to me is a pretty classic example of the kinds of situations that I think all of us as clinicians have encountered. And this is the kind of scenario where I believe that the individuals involved were really concerned that there was a very high likelihood that this particular patient, if this patient went home, was going to suffer a bad outcome. All right. So the idea of against medical advice discharges raises then this question of the against medical advice discharge form. And I don't know what you do at Mary Greeley or where you've done what you've done in other places where you've practiced, because my understanding is different institutions and different clinicians handle this differently. At our hospital, and this is a copy of ours, we do have a form that we can use. We don't have to use it, to my knowledge, but we're allowed to use it. And I think different clinicians have different thoughts about this. I know this is one article that basically recommends against the use of these forms because one is they don't believe they're required, they don't believe they actually work, and they don't believe they help the doctor-patient relationship because it could even inflame it or exacerbate or aggravate it. And some might even go further and say that there's something almost punitive about asking a patient to sign something that basically says, I'm being a bad patient, right? You can see. But my take on this is to say that I understand why many clinicians, including myself, in certain circumstances, would see the wisdom of using these forms if we use them the right way, right? There's a way to bully a patient with a form like this or try to. There's also a way to calmly, respectfully, but very seriously use this form as a way to document that you've done your work properly, and there will be no question in the record that you have done so in the future. And it also, I think, very importantly, gives the patient one last opportunity to decide, maybe the doctor might be right, and maybe I should keep thinking about this. Okay. So, but if any of you are not inclined to use this form, you'd be in agreement with the authors of this paper referenced over here, who basically would say that you could sort of treat this as any other informed consent process where you still document it in the chart, but you don't necessarily have to use the form. So I think it's an open question worthy of all of our reflection. So in the situation like I described about this patient refusing a cardiac catheterization, it now raises the question of how hard do you try to change this patient's mind? Okay, so certainly the patient got information, the patient got a recommendation, and then the question is how many times does the cardiologist or the primary team do they try to persuade the patient? Here's the definition of persuasion in healthcare that I and colleagues have put together, even for study purposes. I think it's a good definition. See what you think. Persuasion in healthcare is attempted when, after having communicated information and a recommendation, a healthcare professional uses reasoning to try to change a patient's thinking toward a decision that is more consistent with the healthcare professional's understanding of what is good for the patient's health. I would encourage you to spend some time thinking about just the way that's phrased, to see if you agree with it. I'm not obviously you may not agree with it, but hopefully you'll. I would hope that you'd agree that what it's emphasizing is one is that the professional is using reasons, not just bullying tactics to try to wear down the patient to get the patient to sign on to what the doctor wants, but to actually give reasons that then the patient can think about and either accept or reject, right? And what I also appreciate about this definition is that the end of it, it's acknowledging that this is what the health professional thinks is good for the patient. It's not necessarily what the patient thinks is good for the patient. And that's why, at the end of the day, we need to accept the patient's no as the final answer, right? But there's an honesty, there's a transparency about the way we can talk to patients by saying, listen, I've tried to understand your perspective. I am trying to help you understand my perspective about what I think would be best for you. And I want to make sure I've done my job properly so that I can then be satisfied that I can do no more and I've done enough. Just as an aside at the bottom, it touches on this notion. You may have come across it in articles about nudging. Nudging is different. You can, on your own time, you can read that definition here. but it's actually not giving reasons transparently. It's using other means, which I think at least some would say could constitute and would constitute manipulation. That's not what I'm talking about. So just in case you're interested, a medical student and myself and some others did a project here at the University of Iowa where we interviewed over 200 medical students. And you can see here the percent agreements that, not surprisingly, most medical students agree with the goodness and the appropriateness of informing and making recommendations. But look, it's about a 50-50 split about whether persuasion is appropriate. I suspect that's not unlike, the medical profession to some degree, though I suspect if you were to interview doctors, that number would go up. And then you can see here that we asked about specific principles like autonomy and beneficence and non-maleficence. And clearly it's the case that persuasion is considered appropriate when you believe it promotes beneficence and non-maleficence, but it's considered inappropriate if you believe it disrespects patient autonomy. Right? So the ethics seems to be very much in the forefront of the way we think about what we think we're doing when we persuade or not. Okay, and then it's interesting how about half of students said that even as a medical student, they're willing to participate in attempts to persuade patients. And then it goes up to about 70% of students in total who say that, but even more so when I'm a physician, I'd be inclined to take on the responsibility of persuasion in that sense. So just you can again, anybody's interested, I'd be happy to send you a copy of the article if you want to read the details. And one more slide from that study. We actually just did some bivariate analyses and clearly got some very strong, odds ratios and p-values that show the correlation between that. If you believe that persuasion promotes beneficence and non-maleficence in various ways where we inquired about examples of persuasion, you're clearly much more willing to use persuasion if you think that it's ethically justified, which in one sense is just common sense. That's what you'd expect. But sometimes you see some pretty striking, significant differences in p-values, and it just really brings the point home. Okay, so in terms of ethics, the ethical rationale is that persuasion is justified by beneficence and non-maleficence. And this really goes back thousands of years, basically, to the Hippocratic commitment to beneficence that creates a duty to try to persuade patients to try, not to necessarily succeed, right? That's finally the patient's call, whether it's going to succeed. But to try respectfully and compassionately and patiently to help patients pursue the medical course of action that the physician or clinician believes is most beneficial and least harmful. Another way to think about this is, and again, it might seem a little busy. I think once you take it in, hopefully it'll be helpful. And that's to say that here on the y-axis, you have the degree of respect for the patient's free decision, whereas on the x-axis, you have the degree of intended influence on the patient's decision. So that when you move from inform to recommend to persuade, an honest approach would be to say that you are trying harder to influence the patient's decision. You're ramping up the strength, right? But hopefully, no matter that you're going from inform to recommend to persuade, you are sustaining the same level of high respect for the patient's free decision at the end of the day. Whereas, if you go beyond persuasion to manipulation and coercion, I believe it stands to reason that you do not intend to respect your patient's free decision. Hence that red cliff there. So hopefully that makes sense. Now shifting to the other side of the disagreement. So the first example of AMA discharge is we recommend something, patient refuses. Now the flip side, a family insists on something that we would like to refuse, but struggle to in some cases, like this one. So there was a 78-year-old woman with a history of metastatic adenocarcinoma who was admitted to the ICU after a cardiac arrest. Following post-arrest hypothermia protocol, she remained intubated and on multiple vasopressors. Brainstem reflexes appear to be absent, and multisystem organ failure was developing. Prognosis was extremely poor. Multiple discussions were had with the family about code status, but they decided on full code. 2 hours later, she had her first cardiac arrest. And after 20 minutes of resuscitation, she returned to sinus rhythm. After another hour, she arrested again. After another 30 minutes of resuscitation, she again returned to sinus rhythm. After another hour, she arrested yet again. And resuscitation was attempted for 15 minutes before it was decided that it was not going to help. The code was stopped and she was declared dead. So I think that's about as classic a sort of case as you can think about or find where a medical team believes that a particular intervention, in this case, resuscitation in the ICU, is basically not going to work. And so I think for some, they would basically say it's going to be futile, right? At that level. So to talk about medical futility is then to get into the weeds and the swamps of, okay, exactly how you define it. Here's one article now from what, 1990, so over 30 years ago, that wanted to try to persuade everybody that if one of these three items were satisfied, either less than 1% chance of success, or you can only maintain life in an unconscious state, or life was unsustainable outside of an ICU, the patient should be, the treatment should be, the life-sustaining treatment should be considered futile. Well, that didn't persuade everyone because you can argue about these things, and people do. And I certainly know in my own work as a clinician and as a clinical ethicist in my hospital, um, this is contentious ground. So consensus is lacking on that. Once again, you saw this slide before, the idea of the dimensions of decision making. I'm going to show on the next slide a way of thinking about futility that gets mapped on top of these different dimensions here, okay? So one way to think about it is to say that there can be different senses of futility or different grounds for a sense of utility. So if the probabilities are too low, you might call that quantitative futility. If the burdens are too great, you might call that qualitative futility. If the costs are too great, somebody might want to use a notion of economic futility. I'm not recommending that, but in my experience, that is certainly on some people's minds, especially in the ICU. The the dimension in which I think we're going to do our best as justified reasoning clinicians is in the goals domain, so that if the goals are unachievable, then we can have a goal-oriented sense of futility. I think that's the most compelling. So in the case that I just walked through on the prior slide, that would be a situation where a clinician can go to the family and say, your goal is to sustain your loved one's life. That goal really is no longer realistic. It just isn't. Yes, I mean they could say, well, we might get one more successful resuscitation. Well, that's true, but within a reasonably short period of time, as in hours rather than days or weeks or months, one can say legitimately to a family, it's not going to work, right? Again, there can be room for some disagreement in some such situations, and we need humility as clinicians and patience and compassion. And sometimes families just need more time. I understand that. I think you understand that. But the point is I would encourage you to think in goal-oriented language whenever you think about questions of futility. And on that note, if you're not aware of this article, it's a good one to have in your files because this is probably the most commonly referred to sort of consensus white paper on how to think about futility or this notion relatedly of potentially inappropriate treatments. This group, I think quite wisely, reserves the word futile or futility for interventions that can't accomplish their physiological goal. That's a very high sort of threshold to meet. Whereas they take very seriously something not quite that, you know, absolute, but to say that, but there are a lot of situations where the treatment is potentially inappropriate because clinicians believe they're not sufficiently justified, even if they have at least some chance of accomplishing the effect, right? Because that's that at least some chance of accomplishing, that's different than being able to meet not being able to meet the physiological goal, but it's still not sufficiently justified. I think that's a helpful sort of discriminating contrast that if it's not how you think about it, I'd encourage you to give this article a read and see what you think. Another idea, I'm sure some of you are very familiar with this, is the whole issue of time-limited trials, especially in ICU care. So often there are uncertainties, I mean, most of the time, so we can't over speak. We can't sound more confident than we have a rational basis to be. And also, as already mentioned, families need time. And so this idea of a time-limited trial is really wise. And it also has within it a sense of humility that is willing to persevere, to be patient, to see how the next step goes. And this is a very nice piece written in JAMA Internal Medicine in 2021. I highly recommend it if you don't have it in your files. The AMA Code of Ethics also has a nice statement on what they refer to as medically ineffective interventions. And they acknowledge that futility assessments depend on values and goals. And so in that sense, there's going to be debate about them. So there's a nice note of humility and honesty there. But they also acknowledge that there are situations where a physician determines that it's medically inappropriate to do what the family or patient is asking. And then it lays out a stepwise procedure of how to deal with that. And they also end by basically saying that if the physician believes this is a medically ineffective possibility, the physician is under no ethical obligation to offer the intervention. And then the question will be is how do you transfer care to somewhere else, et cetera, et cetera. It gets complex, but it's a good statement to read through. It's not that long, and so it's a good, if you're not familiar with it and you're interested in this area, I encourage you to take a look at it. So just a couple more slides wrapping up here. I think in the big picture, to try to summarize a lot of what I've said, I think there are at least two different ways of viewing our patients. And you could see patients as autonomous choosers. And that's going to be really, in a sense, reflecting an autonomy-based and information-based approach to the process of shared decision-making. Whereas if we see our patients as interdependent persons, then we're getting at these notions of relational autonomy that will also incorporate beneficence and non-maleficence and will very transparently remind us of why it is we not only give information, but also make recommendations and sometimes attempt to persuade our patients. So that's that big picture way of kind of putting this twofold framework together. So my recommendation is that we at times use respectful persuasion, but we have to do this with caution and of course with respectfulness. And I think as I've thought about it, and I've thought quite a bit about these things, I think these would be my sort of top ways of saying how we go about this in a way. You can see this picture here, it shows a guardrail so your car doesn't go off the edge of the road. So there's a sense in which, and for those of us who from time to time have had occasion to drive on some pretty dangerous roads, I've certainly been in the Rocky Mountains in some places where I really wish there had been guardrails. And it starts to be really nerve-wracking till you just don't want to look, out your window and down. So the point being is that we need guardrails to keep us from crossing those boundaries over into manipulation or coercion. We don't want to go there. I hope we can all agree on that. So how do we do that? How do we stay in our lane and on the road, the proper road? We explain our motivation. We just honestly, transparently, sincerely say to our patients, listen, sir, ma'am, my friend, I'm concerned about you and the decision that you're voicing here. I'm really concerned. I'm concerned about your interests, not about me or my time or my hospital or anything else. I'm concerned about you. And then we give those reasons. Remember, that's that difference between relational autonomy and persuasion versus that idea of nudging, where you're basically manipulating. By giving reasons, I'm handing something to my patient and saying, consider this, you decide. And then I acknowledge to myself and to my patient that he or she has the freedom to disagree and refuse. So I remind them that I'm not here to get the last word and the last decision. No, it's my patient's call. I believe that when we do this well, we're promoting the patient's autonomy by giving our patients more opportunity to think and deliberate with people who care about them. And I think, of course, a key ingredient to this is trust. So the ethical framework then is about respecting persons and fulfilling our conscientious practice. It's about relational autonomy and transparency and trust. So thank you very much. We're right at 1 o'clock, and if I recall correctly, uh, we have 10 minutes more for any discussion, questions, comments, rebuttals.
Not
Anyone
so much a question from me, I guess. This is Amber.
Hi, Amber.
Yeah. Hey, I may actually send you our version of our AMA form because we had recently updated it to include the risks and benefits listed on that form. And we want to make sure that they are gone over with the patient and it's documented. So I thought you might find that interesting, and I'll probably share that with you later.
Yeah, I very much like seeing those kinds of forms, and I think that's really wise to have room for more information so that everybody is satisfied that that's been communicated and documented.
Mm-hmm.
That's good. Anybody else?
It doesn't look like it.
Okay, well, it's been a delight to be with you all again. And if anybody has any follow-up communications they want to send in my direction, please, if you can remember how to spell my name. Okay, here. Well, sorry. Here's somebody who has. Sorry, did I lose that? Okay, is it possible in an emergency after provider gives information to patient and give them time and come again? Um, I think the grammar is a little. I'm not sure. I think there's I'm not sure how exactly what that's saying, but I'll take it to be saying, what about emergencies where you don't have time? Um, I agree. Emergencies are a special case, right? And actually, on that note, let me just I'll let you know. I didn't say this before, but this is a nice segue back to the first case that I presented. Okay, give patient time. But yes, yes, yeah. Okay, I see. In you put non-emergency. It says non-emergency. That's what threw me off. Yes, thank you. Uh, it looks like it's Nadia. Thank you for saying that. That would be very appropriate and very wise. And so often I think things get revved up and ramped up and really sometimes even tense and ugly because, and you heard me use the word, the virtue, patience. And so often, and in fact, in cases that I'm familiar with, I think the best clinicians, they have the first round and then they say, would it be okay if I come back, if it's an inpatient, let's say, this afternoon, or let's discuss this at the next clinic visit, or I'll call you tomorrow if that's okay. But I completely agree. When you don't have to make a decision right now, don't stress out and add even more strain to a strained situation. But let me say that the emergency context of that patient who wanted to go home without the cardiac cath, sure enough, the patient was readmitted the next day with a heart attack, the myocardial infarction. So the clinicians were right on track. Clearly, patient wanted to come back because he came back to the hospital. So it's those emergency situations that are certainly the toughest. And there was another, and what age limits for consent from Dr. Kitchell? I I think, well, certainly, the standard age of majority, but then those of you, I think we all know that in certain the law in state law, there are carve outs for certain age lesser age limits that are available for certain clinical settings, like sexually transmitted diseases, et cetera. So I don't know if Dr. Kitchell, if you wanted to say any more about that.
While he's working on that, we do have a question in the audience actually as well.
Okay, please go ahead.
Yeah, I really appreciate the subtle distinction you make there between autonomy and relational autonomy. I'm wondering if there's like a social trend towards one or the other, particularly in terms of treating people with PTSD.
That sounds like a really interesting question. Because I'm not in psychology or psychiatry, I'm not aware. Do you want? Can you say more? I'd be curious to know if that's your background, to say a bit more about the PTSD context.
Yeah, I'm just I'm a chaplain and I work in sometimes in behavioral health with folks, and just some of my background training was that kind of leans more towards the autonomy rather than the relational autonomy with that patient population, from what I understand about this definition. So I'm just curious if there's a trend in that direction towards that kind of, or maybe I'm just getting clearer on what autonomy means. I really appreciate this distinction that you're making here, and the encouragement towards persuasion in a non-manipulative way.
Yeah, no, I think that's an interesting line of discussion there. I don't know what trends. I don't think that I'm in a position to be able to comment on trends. And in fact, what I find it's in one sense it's kind of disturbing, is that, and we're not going to go there. I'm not going to go there right now. But if you think about some of the more contentious areas in our society right now. I mean, I'll just take vaccines, okay? Because everyone gets it. And people disagree, and there are a lot of different kinds of disagreements about that topic. But it seems to me that a given clinician might take quite a different approach to how much to lean in, depending upon the clinical question. Depending upon how strongly they think and feel about the rightness or wrongness of something. And so I even wonder whether within a given clinician there can be variations as opposed to a general temperamental approach to these things in every case. And then what I also think is that on the relational side, I think that the more we focus on in a sense the way we look at patients and the need of a patient, and the more critically ill patients are, those of us who have been clinicians, we know that the patient's vulnerability needs help. And so it also, I think, reminds us that it would actually be a dereliction of duty to not help bear some of the burden of decision making. But having said that, I think what we should all be striving to do is to understand and get to know our patients and their families well enough to know who they are, so that we don't have a one size fits all in every case. I've certainly cared for patients over the years where some of them, they're telling me what to do. Clearly the locus of control is coming from them. And I almost have to get permission to join the conversation, right? As opposed to other patients. I remember a patient of mine who, he asked me what I thought about what his code status should be. And I turned the question back to him and I said, sir, it's really important that you base that decision based on your foundational beliefs and values, et cetera, et cetera. And he just stared at me. He wouldn't take his eyes right off of my eyes. And he says, I want to know what you think. And I realized, and I had an outpatient longstanding relationship with him, and I realized he wasn't going to let me go. And so I said, well, based on the situation, I believe that resuscitation would not be in your interest. And he said, okay, we're done. That's my decision. And so it was a really interesting back and forth where I was trying to, in a sense, be respectful to find out who is this man, this patient of mine, and then be for him what was needed in that moment. So I think hopefully, we can all learn to do that dance back and forth where we're basically being responsive to the particularity of this one human being.
Thank you so much. I feel like this is such a subtle but important distinction between autonomy and relational autonomy. And I feel like it's given me a little bit more room to make choices myself for how to work with various patients.
Thank you. Well, I appreciate that. And it's a challenge, and it also takes time. And I think that there would be probably more clinicians who would like to do this sort of shared decision making if you could give them 36 hours in the day, right? So it is a challenging reality. So I'm looking at Dr. Kitchell's further comments, and he's giving examples of transgender care and vaccines, and the question of age of consent, et cetera. I think those are important questions to be thinking about for sure. And as we know in our society, people have disagreements about them. And then Najia says, sometimes some treatment is hurting patient, but patient pushing provider to give them, for example, too much narcotics. In this case, what is right ethically? Yeah, that's that I think is a really nice example of how the patient voices a preference. And if you take the view, remember at that slide where I said patient as autonomous chooser versus patient as interdependent human being. Autonomy versus autonomy and beneficence and non-maleficence. On the request for opioid, prescriptions for non-cancer related outpatient pain, I certainly, as a primary care doctor, had plenty of situations where there were very tense exchanges with patients who were frankly demanding that I refill a prescription that somebody else had initially filled. And I was unwilling to do that because I did not believe the opioids were in the best interests of the patient. Each clinician has to make that determination. That's what's hard about that. And you do your best. But at a certain point, I think that's why even having this kind of language to say to a patient, sir, I don't believe that if I refilled that prescription, doing so would be in your best interests. I realize you and I disagree about that. I've said that to patients in the past. I think there's a healthiness about just being honest about that, putting it on the table. And then I've even at times said to patients, I realize that there are some other doctors who might be willing to give you that prescription, but I, by conscience, can't do that because it would undermine my integrity. I've said such things occasionally to patients. And, there were times when I literally thought a patient might be physically violent toward me because things were so intense. Thankfully, that never happened to me, but I'm sure it's happened to some others. Well, it's 1:13, and I've already stayed 3 minutes past my welcome here. It's been a delight, and I appreciate the back and forth here. Thank you all, and I hope you have a really good rest of your day, and take care.
You as well. Thank you so much for joining us again.
Okay, bye-bye.
Bye.